This is chapter 18, which deals with other immune types of disorders. Hypersensitivities, there's four main types, 1, 2, 3, and 4. And hypersensitivity is just referring to when the immune response against some foreign entity, some foreign antigen, it's responding, but it's greatly exaggerated above what should be normally the response. Almost to the point where you're like, you didn't have to be quite that responsive. Type 1 or immediate hypersensitivity, this can either be localized to a certain region or it could be systemic. Basically what is happening is you have the release of inflammatory molecules as that response to that antigen. It can develop within seconds of exposure to the antigen. Commonly, we refer to this as allergies, and so the antigens are often called allergens. Often what is happening is, as you can see in this diagram, is the antigen or that allergen, it is engulfed by the antigen-presenting cells, as normally you would see, and it presents that antigen stimulating the helper T cells, which in turn stimulate or activate the B cells, which become then the plasma cells secreting the antibodies. And then you have this massive release of antibodies, which in turn are going to start the whole process of binding to the antigen. And then they also are going to be binding to the mast cells, basophils, and eosinophils. So when the antibody binds to one of these mast cells, basophils, or eosinophils, what happens then is that oftentimes the cell releases, it's called degranulation, it releases those histamines, those inflammatory molecules that are in the cytoplasm. So the mast cells, they are throughout the body. They do have those granules. That's what gives it the look of why we call them the granulocytes. When you do the stain, it looks like it has sand dumped in it. A lot of those are due to high concentrations of these inflammatory chemicals that get released then when the antibody binds. What are some of these molecules? Things such as histamine, which causes irritation and causes smooth muscle contractions. It increases the permeability of the blood vessels. Another molecule are the kinins. They also trigger the inflammatory response. They also trigger smooth muscle contraction. Proteases, which can activate complement, which in turn is going to lead to cell death of the foreign substance. It can also cause the synthesis of leukotrienes and prostaglandins. And as you can see, a lot of these do have similar type of responses. The basophils, these also contain inflammatory chemicals. And just like the mast cells, when they counter the antigen, they're going to be releasing a lot of these inflammatory compounds. Eosinophils can trigger or they can be released from the bone marrow by the mast cell degranulation. And then as they are in the bloodstream, they release large amounts of leukotrienes. They can increase the severity of this type of hypersensitivity response. As I said earlier, some of the signs can be very localized, can be mild, and this sometimes this is what some people may experience as hay fever if they've inhaled the allergen. It depends on the portal of entry as to what the response is going to be. So if you inhale it, you can have the sneezing. May cause some asthma. Some allergens may cause inflammation on the skin, and you see that expressed as hives or as rashes. What are some common allergens? In A, you can see some fungal spores. Some B, you see pollen. And on C, you can see small things such as mites, which I'm sure everybody wants to see that enlarged and magnified to that size. And like I said, you get hives or these rashes that may develop on the skin due to contact with those allergens. If a lot of the mast cells start to degranulate or release these chemicals all at once, you're getting a huge release of histamine, a huge release of inflammatory chemicals that trigger that full inflammatory response. And this can lead to anaphylactic shock, which, if not treated in time, can be fatal. Oftentimes what will happen is an anaphylactic shock is that the bronchial tubes will tend to constrict, and that can lead to suffocation for the individual. You must start treatment immediately, and it is treated usually with an injection of epinephrine. This is what is in an EpiPen that individuals who know that they are severely allergic to something should carry an EpiPen with them. What are some common allergens that can trigger this very rapid and very severe response where it leads to anaphylactic shock? Or things such as bee stings, certain foods like peanuts, shrimp. Although those are probably the most common ones. How do you diagnose type 1 hypersensitivities? You can detect it by high levels of IgE immunoglobulins. You can do skin tests and see what the results are from. This is a picture of skin tests where you're looking at the level of response when the allergen is injected just beneath the surface of the skin. So how do you prevent this from happening? Well, number one, once you've identified what your allergens are for you specifically, avoid them if you can. Sometimes I know that can be difficult. Certainly if it's a food allergen, watch what you eat. Some people will take immunotherapy, or commonly referred to as allergy shots, to help basically kind of like desensitize them. You have to take a series of these injections. They're very dilute, and it has to be repeated every few years. And that can be a help, but some people may not want to go through the shots, and so certainly avoid the allergens. If you are having a response, you can take antihistamines to try to neutralize the histamine that's being released. If one of the side effects that you have is asthma, then that can be treated with a bronchodilator and a glucocorticoid type medication that is going to then, because the response causes constriction of the bronchial tubes, what you want to do is dilate them, increase the diameter to ease the breathing. And then, as I said a little bit ago, epinephrine in severe cases can be given. That tends to relax the smooth muscle. That reduces the permeability of the blood vessels. And like I said, that's usually used as emergency treatment to prevent going into shock. Type 2 or cytotoxic hypersensitivities, these results when cells are being destroyed by an immune response. This can be associated with some autoimmune diseases. Two examples excuse me, of these is destruction of the blood cells when a person is given the wrong blood type. Another example is destruction of fetal red blood cells when the mother and the developing fetus have incompatibility blood types in reference to the Rh factor. With blood, with the ABO blood typing system, a few things you have to keep in mind in terms of transfusions is that there are markers on the surface of red blood cells. Now, this is where it gets sometimes a little bit confusing for people because we do call those markers on the red blood cells antigens. Now, they're not foreign, and we're used to using in microbiology the term antigen for something foreign. So this is where it gets a little confusing. So if I refer to them as the blood group markers, that's on the red blood cell. So depending on what blood type you have, you may have just an A antigen or marker. You may have just a B antigen or marker. You may have both of those, or you might not have any of them. And that's how your blood type is determined. So you're trying to match up the blood type of the individual with the blood type that's going to be received. You need it to be compatible so you do not have a reaction, because in your blood serum, in the liquid portion of the blood, you have antibodies. And so you do not want to have an antigen-antibody reaction occurring. This is one case where when you're talking about a blood transfusion, you have pre-existing antibodies that are naturally from birth in your blood serum. And if the antibody reacts to one of the antigens, the reaction is immediate, and you have destruction of the red blood cells, you have clotting occurring, and the results, like I say, are immediate. There is another issue with, we'll see the examples with the mother, the developing fetus, with incompatibility with a different marker. So these are going to be two different cases. So in this diagram is showing, number one, you have a person that has type A blood. They have an A antigen on the red blood cell. So these antigens or markers are on the red blood cell itself, and they naturally, from birth, actually before birth, are going to have anti-B antibodies floating around in the blood. They do not have to have pre-exposure. Now in this case, in this picture, it is showing you that what has happened is the person has received a transfusion and they've been given type B blood. Type B blood has a B antigen on the surface, or a B marker on the surface of that red blood cell. So what happens when that blood enters into this type A blood patient? They already have anti-B antibodies, which are going to bind or attach to that B antigen on that donated red blood cell. When you receive a blood donation, what you're receiving is just the red blood cells. And so those anti-B antibodies bind with the B marker on those new cells that were transfused in, and you get this binding. It starts to clot. The agglutination is going to, that process of the antigen antibody binding, remember, it attracts complement, and it starts to trigger the complement cascade reaction, which ultimately results in lysis. So now the red blood cells are lysing, which when red blood cells lyse is called hemolysis. Anyway, it's not good for the patient. This chart is showing you on the far left of the screen the four different blood types, A, B, AB, and O. So those markers on the red blood cells, what is on the red blood cell? If you're a type A blood, in the second column you see you have the A antigen. If you have type B blood, you have the B antigen. If you have type AB blood, that means you have both the A and the B antigen in it. And if you have type O blood, you don't have any of those antigens on the surface of your red blood cell. In the middle column, where it is showing the antibodies present, this is telling you what type of antibodies are naturally floating around in your blood. Well, if you're type A, as we saw in the previous picture, then you have anti-B antibodies. If you have type B blood, you have anti-A antibodies. If you have type AB blood, you don't have any of those antibodies. If you have type O, you have both the anti-A and the anti-B antibodies floating around. So when you figure out who you can donate blood to, who you can receive blood from, and I would look mostly at who you can receive blood from, what you need to look at is for the patient, what blood type do they have? And then you have to look at what type of antibodies do they have. And keep in mind that what they would be receiving would be the red blood cells. And it's on the red blood cell where there are the antigens. So, the top row, if you're a type A blood, you have anti-B antibodies, which means you cannot receive anything that has the B antigen on the red blood surface. So if you look at that second column of the antigens present, that means you cannot get type B or type AB blood, because both of those have the B antigens, which would combine with your anti-B and start the whole clotting and complement. So you can only receive type A or type O. A person who is type B blood can receive type B and type O blood. Why can they get type O? Because type O doesn't have any of the antigens on the surface of its red blood cell. Likewise, a person who is type AB blood, notice they don't have any antibodies. So there's nothing that's going to combine with an antigen, so they can receive all 4 blood types. So they are known as a universal recipient. Type O blood has both of the anti-A and the anti-B. So that means if you're a type O blood, you can only receive type O blood. Now, you don't have any markers on your red blood surface, on the red blood cell surface. So that means there's nothing there to react with any antibodies. So if you're a type O, you're the universal donor. You can give your blood to anyone. Once again, if you receive the wrong blood type, there will be clotting that will occur. Another thing which is also classified under the cytotoxic or type 2 hypersensitivity, deals with the RH system, which also is with blood. There is what's known as the RH antigen. This is common on the red blood cells. 85% of humans are what we call RH positive, meaning they do have this antigen. If you're RH negative, it means that you do not have the antigen. In most cases, this is not going to be a problem. Where the problem arises is if you have a woman who is RH negative and she is pregnant and the fetus is RH positive. Now, if this is her first pregnancy and she has never been exposed to RH positive blood, it's not going to be a problem. The problem would be in any subsequent pregnancies. What would happen is there won't be an effect on the mother, but on the developing fetus. She may have produced anti-RH antibodies, which can cross that placental barrier and can cause what we call hemolytic disease in the fetus. So there's a way of trying to prevent this as best you can. And what they would do is they administer a drug. They give the pregnant woman a shot of what's known as Rogam to try to reduce the chances of hemolytic disease. So what happens in this diagram is it tries to explain this. In the first pregnancy, mom is RH negative. The developing fetus is RH positive. Throughout the pregnancy, it should be fine, but then during birth and delivery, the mother is going to be exposed to the baby's blood. And when the placenta breaks, some of the blood does go into the mother's stream. So what would happen is because the mother's been now exposed to these RH antigens, she produces anti-RH antibodies. Any subsequent pregnancy, what would happen, she still has these RH antibodies. And so, like I said, they can cross that placental barrier. And if in a subsequent pregnancy, the developing fetus is RH positive, then the antibody binds with the antigen and you start the whole process again of stimulate the complement and destruction can occur. So what they will do is they will be testing the mother's blood as soon as they know she's pregnant. Usually around week 28, they will give her a shot of Rogam, and then right after delivery, they give her a second shot. The idea is that this ties up any of the antigens, hopefully preventing her from ever producing those anti-RH antibodies. And certainly in any subsequent pregnancies, they will monitor very, very closely. They will monitor the health of the developing fetus. If the fetus is Rh positive, they will monitor very closely. Depending on circumstances, they may need to do a blood transfusion on the fetus right after birth. It depends on how well they've been monitoring the situation. Type 3, which is known as immune complex-mediated hypersensitivities. This basically triggers the inflammatory chemical release again. There's several different types. Some of them can be localized, some of them can be systemic. And there are examples that are listed here. Basically, once again, antigens are going to be released. They combine with the antibodies, forming the complex. This triggers phagocytes to come try to remove some of the complexes, but some of the complexes may not be engulfed and removed. They may attach to the walls of, say, blood vessels. Complement gets activated, and then that attracts neutrophils, which are going to release various enzymes and chemicals that trigger inflammatory response and ultimately causes some damage to underlying tissues. A short time period of the inflammatory response is okay. Long-term or a chronic situation does cause tissue damage. With hypersensitivity pneumonitis, which is a type of, or falls under the type 3, basically this is where you are having problems in the lungs. You've inhaled antigens that have been able to penetrate deep in the lungs, and you start to have that activation of the complement, can lead to damage of the lungs. The next one, glomerulonephritis. This is with the kidneys. The glomula and the nephron and the kidneys are part of the functional unit of the kidneys, allowing for filtration. And so this affects the ability of the kidneys to filter the blood, can lead to kidney failure, and ultimately if the kidneys fail and you're not filtering the blood out, this can lead to death. Another example is rheumatoid arthritis. This is affecting the joints. They start to break down, become very distorted. Damage usually starts mild but can progressively become more and more severe with time. We don't know exactly how this starts. It can be treated with anti-inflammatory drugs, and this can lead to very severe deformities basically at the joints, as shown in the hands here. And then another type is systemic lupus, where basically antibodies are being formed against your own cells. There are different medications that can be used to try to help with the treatment of this. Part of the problem is it's often immunosuppressive drugs, which then of course makes you susceptible to any other types of infections. You can also receive medication to help reduce the inflammation. And this is an example of a rash that's often seen with lupus. Type 4 is delayed or cell-mediated hypersensitivity. As the name implies, you don't see a response right away. It's delayed about 12 to 24 hours after contact with the antigen. The delay is due to the T cells being stimulated, the macrophages coming in. All of this takes time to kind of get up and running. One example of this is the tuberculin response. If somebody has never been infected or vaccinated against Mycobacterium tuberculosis, the causative agent of TB or tuberculosis, there would be no response when they are exposed to antigens. If someone has been infected previously or has been immunized, then there would be, over time, once again, it's not immediate, you would see typically a swelling. It's going to turn red. It's going to look very hard. Anyone who works in medical healthcare field has to be tested for TB on a regular basis. So some of you may be familiar with this, where they will not only look for this red hard swelling, but also measure the size of it. And so that's an example of a positive TB test. Another example is what we call the allergic contact dermatitis. Contact dermatitis typically you see as a very strong skin rash that is triggered when your skin has come in direct contact with something foreign. And then typically, like say 12 to 24 hours later, you start to see the rash forming. You may have blisters forming. It may be what we call weeping type blisters where it's releasing fluid. Some examples of this, certain cosmetics, if you're allergic to, you may have noticed this. Some people who are allergic to latex have this type of reaction. Poison ivy is a classic example. And usually you can treat this with corticosteroids. This is an example of what contact dermatitis looks like, which once again is a type 4 hypersensitivity reaction. Graft rejection, this is when excuse me, an individual has received some type of either tissue or organ transplant and their body perceives it as, oh, this is foreign, this is not part of you. How does it know that it's not part of you? It's because, remember, those MHC proteins, major histocompatibility complex proteins, that are unique to you. If you received a tissue and organ from someone else, obviously the MHC proteins present on that donated organ is different than what yours are. And so your immune cells are going to be able to recognize that. How severe or what are the chances of rejection occurring? It depends on the type of graft that is received. This is showing there's 3 different types of grafts. An isograft would be where it's genetically identical. It's a clone. An allograft is where it's genetically it's different, but it's at least from the same species. And then a xenograft is where it's from a completely different species. The graft versus host disease, once again, your body's recognizing MHC, whether it's the class 1 or the class 2, depending on where the graft came from. Bottom line is, how do you treat this? You're going to have to receive immunosuppressive drugs to prevent this reaction from occurring. The more closely you can match a donor recipient, the better off you're going to be, because the more closely they're related, the less differences there are between the MHCs. That's why if you are needing to do, say, a tissue graft or even an organ transplant, you first start by looking for family members, somebody who's going to be very closely related, because those MHCs are going to be typically more similar. So start by looking at a parent or a sibling and then gradually move out from there. So this table is showing a summary of the 4 different types of hypersensitivity reactions, names of them, different causes, characteristics of them. Some examples here of type 4 delayed hypersensitivity. As I said, you can give immunosuppressive drugs. That is usually very helpful, and these are some different classes of drugs that help to suppress the immune system so you do not have some of these issues. If you look at autoimmune diseases, there are several different causes for these. They tend to occur more often in the elderly. They tend to be more common in men than they are in women. And for whatever various reasons, an autoimmune disease, what's happening is an individual starts making antibodies against their own cells, or the cytotoxic T cells start acting and against and destroying some of your own cells. What are some of the causes for autoimmune diseases? We don't know all the causes. It appears that certain hormones like estrogen may stimulate some of the destruction of tissues by cytotoxic T cells. Sometimes it may be environmental factors. Some of it may be genetic factors. And abnormal regulatory controls of the individual's immune system. There are different categories. Some autoimmune diseases may be systemic. Some of them may just be affecting a particular organ. So some examples where you have affecting just certain cells, like autoimmune hemolytic anemia. What is happening here is the person is producing antibodies against their own red blood cells. So that's going to cause anemia. We don't know exactly what triggers this. We have seen sometimes it happens after a viral infection or after treatment with certain drugs. Another example is type 1 diabetes mellitus, where you have damage to the islets of Langerhans in the pancreas, and you can treat this with immunosuppressive drugs, can help delay it. It does eventually cause destruction of the gland, and the hormone deficiency follows that. Graft disease is an autoimmune disease against the thyroid gland. It triggers excessive or overproduction of the thyroid hormone, and then the thyroid gland itself grows excessively. You can try treating this with medication or with radioactive iodine, and sometimes you may have to actually remove the thyroid gland completely. MS, or multiple sclerosis, is with the nervous system. What happens is cytotoxic T cells destroy those myelin sheaths that are helping to insulate the neurons in the brain and the spinal cord, and ultimately leads to impairment of speech, impairment of vision, and impairment of neuromuscular functions. Rheumatoid arthritis, which we've mentioned before, is also an example of another autoimmune disease. So if you have a defective immune system, there's two general types that they'll be classified as. Primary immunodeficiency diseases, this is when the result is from a genetic or a developmental defect. It develops in infants and young children. An acquired immunodeficiency disease is one that is usually developed later in life, and there is some direct cause. We can say maybe there's an infection and this causes this particular disease. So some primary immunodeficiency diseases are shown in this chart, and you can see what the defect is and what the resulting thing will be, such as severe combined immunodeficiency disease, or SCID. The defect is there are no T cells or B cells, which means you have absolutely no resistance to any infection. So your outlook is not very good at all because you're susceptible to everything. The acquired immunodeficiency diseases, which are seen, as I mentioned a bit ago, in adults, there can be several different causes of it, sometimes stress, sometimes environmental factors, sometimes malnutrition. One type or example of this is acquired immunodeficiency syndrome, which is known as AIDS. The causative agent for this is the human immunodeficiency virus, or HIV. The HIV virus, what it does when it attacks the individual, and we will cover this later when we talk about viral diseases. Basically, it starts to destroy the helper T cells, specifically the CD4 cells, whose purpose is to help stimulate even more cytotoxic T cells and also stimulate the humoral or the B cells. So if it causes low CD4 cells, essentially you're turning off the immune system, which is very bad for the individual, but very good for the virus. If the immune system is basically shut down or turned off, then that means the individual is susceptible to opportunistic infections, those that normally would not have caused any problem in a healthy individual, but now can cause severe infections in this individual.